Eric Lim that reported about the VIOLET study, that is a multi-center randomized clinical study of VATS versus open lobectomy for lung cancer.
Great, thank you very much. I'd probably give you a lay summary of what I've been presenting today in the earlier conference. At the moment, if you have early stage lung cancer, many of your doctors will refer you to see a surgeon because we think that surgery would be able to remove all the disease, and that would be considered the best treatment if it is very small. Now, the operation can be done two ways. It can be done through little incisions and telescopes and instruments or projected on a TV screen, or it can be done via a big cut in the chest with the ribs spread open with the hands in to get your cancer out. We think that keyhole surgery may be less painful and have a better recovery because we don't actually put pressure on the nerves when we're opening the chest. When we do the operation open, we have to use a metal rib spreader, and that can sometimes injure the nerves. But if we are going to do a keyhole operation, how is it that if a surgeon cannot use his eyes and cannot actually feel the cancer, would he be able to get as good a cancer removal compared to just using instruments on a TV screen? So for the clinical trial, we had to define what was keyhole surgery, and we ensured that the surgeons can't use their naked eye to see inside the chest, and there was no rib spreading. And principally for open surgery, the surgeon could see inside the chest, get his hands in the chest, and also spread the ribs to get access. We made sure that the lymph node harvesting and pain management was standardized, and after the operation, we had a big dressing over the wound, so you couldn't tell if you had a keyhole operation or if you had an open operation. In fact, we actually tested the patients. We asked them, can you guess if you had a keyhole operation or an open operation? And actually, none of them could. So there's a 50% correct guess, which is no better than flipping a coin. We screened over 2,000 patients. We've randomized over 500 patients. We achieved it to time and to target. And we had very good surgical quality. We had a very low mortality rate. We had a very low benign resection rate. Keyhole surgery was performed through 3 keyholes in the majority and 1 keyhole in about 20% of patients. We had a very low conversion from keyhole to open surgery, and that's a marker of the maturity of the keyhole technique. If the conversion rate was very high, then we would have concerns that the keyhole surgeons maybe weren't that good. But in our study, our conversion rate was relatively low. We found that pain was lower in the keyhole operation group. And having adjusted for all the painkillers, it resulted in half a unit lower pain score. The need to adjust for painkillers is very important. If you have a cut and your pain score is 1 out of 10, your pain score could be 1 out of 10 because you're on 1 tablet of paracetamol, or you have 10 milligrams of morphine. So the paracetamol and the morphine dictates your pain score, not actually how much pain you perceive. And that's why for this sophisticated analysis, we had to adjust for each and every single pain medication patients received. The length of stay for open surgery was 5 days, and it's 1 day shorter for keyhole surgery. And we did more sophisticated analysis to adjust for any other confounding variables. In terms of cancer clearance, we found that the number of lymph nodes that were harvested was the same in both groups. The number of lymph nodes harvested is very important because it can change your treatment after the operation. If you have N2 disease, patients will be recommended chemotherapy. If you have N1 disease, all these are important. And people say that, well, actually, taking the number of lymph nodes out, whether you do it open or keyhole, is not really a big a deal. It's not very discriminatory. If you are a good surgeon and you take a long stretch of lymph nodes out, there's a much higher chance you will pick up disease which was not otherwise detected before the operation. And we found that keyhole surgery, to our surprise, actually picked up even more lymph node disease than actual open surgery. And this is one of the first randomized trials to show this, because all previous studies, mainly that were not randomized, showed a very big difference in lymph node upstaging. It was much better with open. But when we used the surgeon as his or her own internal control, we found that access didn't actually make any difference. what we found was a startling 26% reduction in hospital complications if you had keyhole surgery with no increase in any serious adverse events. And whilst bleeding occurred in the keyhole surgery arm during the operation, it also occurred in the open surgery arm. The benefits for keyhole surgery were mainly reducing kidney complications and infection complications. So we concluded that keyhole surgery is less painful, has less complications, leading to a shorter length of stay in hospital for our patients. And this was achieved without any compromise to cancer clearance of the cancer operation and without any compromise to any serious adverse events compared to open surgery for lung cancer. Thank you very much.